There's a gentleman from Kenya on there. Dr. Nyaga, can you hear me? I'm going to see if I can allow you to speak. Got it. Dr. Nyaga, can you hear me?
Yes, Doc. How are you?
I'm fine, thank you. I just wanted to say hello. I saw you. Dr. Nyaga is an instructor at the University of Nairobi in Kenya. And so I've been trying to bring, Nigeria, Kenya, Rwanda together, and he's been instrumental. In fact, he has mandated all their final year students to be part of this webinar series.
We should. Yes, and I tried to rope in all my colleagues prosthodontists also to join. So I shared the link with them. I hope some will be able to join. No and problem. I also shared the lecture for the previous lecture by colleague with them, and they are very excited. Thank you so much.
That's wonderful, James. That's really wonderful. I think it's terrific that they want to come on a Sunday afternoon. I think it's just before dinner, so talking about chewing might make them very hungry. So,
all right. So, I mean, I guess people are going to join. We just, I think we are on. But thank you once again, Dr. Cooper. I mean, I've looked up to you for a very long time, and I still do. and I've read most of the articles that you've written. It's been used in different universities as topics for us to discuss, and it's a privilege to have you come in today speaking about overdenture, the mandibular implant overdenture, planning and the execution of it. That'll be please take it away, sir. Thank you so much.
Well, thank you, and good morning, everybody. Or I should say good evening, everybody. Yes. So it's a pleasure for me to return with Uvo and talking about today the mandibular implant overdenture prosthesis. This is where I think my career began, and is something that I still find to be my most favorite clinical therapy. Unfortunately, today we don't have time about making new dentures, but I would like to share with you some simple rules that will avoid complex problems in your making of implant overdentures. We're going to focus on how surgery is really about planning for overdenture function. And then we'll go through a couple of examples of a defined surgical protocol. So a little bit of hands-on work today. But I did want to mention, and before you all got on, I think Uvo and I were talking about this, edentialism in the rest of the world, aside from the United States, 50 countries, reflects something very interesting. First of all, in much of the African continent, there is very little data about the edentialism. And then what we can see in various parts of in Africa, edentialism rates are very low. But these dark blue countries, Namibia, Zimbabwe, Morocco, and Western Sahara, they have pretty high rates of edentialism. You see here, Western Sahara and Morocco. And then Ghana has probably some of the best data for edentialism. And its rate is about 2.8%. So this is in contrast where the rate in the United States may be 15 to 20% today. So there's less edentialism, but in parts of Africa, it is still rather prevalent. In the countries you may represent, you may find that there are certainly edentulous people. However, you may also find there are people who need to be edentulated. And what we understand is that edentialism is a true disease, and it is considered a disability. In fact, among all diseases that can affect people, it is ranked 22nd as a level 4 cause of disability by the World Health Organization. What was written by the folks studying this in Ghana, where they have this 2.8 prevalence, is that it has been largely overlooked and hasn't been a huge priority for managing aging health issues in Ghana, but it does take its toll on the quality of life of the individual. And I think this is the message we have in the United States. It's the quality of life, or how people perceive their lives when they are a dentalist, that is probably most important. In the United States, these people are not edentulous, but clearly their teeth have outlived their function. It has created a health issue for them. And periodontal disease in the United States still exists. And this individual is a patient we did treat years ago. And you can see there is a person like this would not be considered edentulous, but the treatment for this gentleman to rid him of periodontal disease, which should have been done years ago, is actually edentulation and dentures. So if you edentulate a patient, then it reduces the quality of life. And based on the World Health Organization criteria, as I mentioned, you are considered physically impaired. And you are considered disabled because of your inability to eat and speak effectively. I think what is most important is what we've learned in the United States by measuring edentulation impact in our older population, is that the absence of teeth affects your social abilities. And so we really think about edentulation as being crippling for our people. What I wanted to share with you is the uplifting message that a mandibular implant overdenture is a powerful therapy affecting people's lives. Multiple studies demonstrate the improvement in patient-reported outcomes that are measured when dental implants augment a removable prosthesis. And we have to recognize that this is a therapy that can be delivered in an economical manner when possible. Now, Jocelyn Fine at Montreal, at McGill University, has said the restoration of the dentures mandible with a conventional denture is no longer the most appropriate first choice. There's now overwhelming evidence that a 2-implant overdenture should become the first choice of treatment for the edentulous mandible. And this is based largely on the data that shows that patients improve their psychological well-being and their physical well-being by using a 2-implant mandibular overdenture. If we look at data from different studies, I can briefly show you that in the mandibular overdenture, the mean difference in quality of life is remarkably higher for patients with overdentures. And the same is true, I don't have time to talk about maxillary implant supported fixed dentures, work done in my own university showing a remarkable change in the quality of life, high numbers being bad quality of life, low numbers being good quality of life. And so just placing implants and making overdentures for people really, really changes the way they feel about themselves. One thing that's interesting, this recent paper, 2021, looking at a large patient population in Sweden, individuals treated with dental implants show a statistically significant lower 10-year mortality compared to patients treated with conventional dentures, regardless of their socioeconomic status. So there are confounding issues here. Perhaps these people take better care of themselves in general, but one can draw the conclusion that dental implants can improve the mortality rate in our population. What about mandibular implant overdenture patients and improved quality of life measured across the world? Well, a systematic review and a meta-analysis demonstrated that would compare with mandibular conventional dentures, implant overdentures were more satisfactory at a clinically relevant level. And so this is what we want to understand. Now, to deliver this care in your practice, we must understand how to do this with minimal impact on our patients and preventing common errors. And I will share with you some rules today and tell you what the most common problems are with mandibular overdentures. But let's just remember that this overdenture is an implant retained prosthesis. The overdenture will still rest on the mucosa, and all of the principles of good denture design are important. Secondly, we know that only 2 implants are sufficient to provide great mandibular overdenture function. Experiments done in the last decade with only a single midline implant demonstrated that this implant could retain the mandibular prosthesis, could provide improved function. However, it was associated with greater repairs and greater maintenance overcoming the cost savings of 1 versus 2 implants. The other point is that you must understand that a resilient attachment connects the conventional denture to the abutments. So we're making a conventional denture, and within the denture are retained some metal housings that attach to these abutments, which hold the denture firmly into place, creating greater stability. To assure that we place our implants in an appropriate way so that we optimize denture function biomechanically, we optimize denture strength biomechanically, and we reduce the risk of harm to our patient. We published a decade ago the so-called Rules of 10. Let me share these with you now. For a successful implant-supported or mandibular retained mandibular prosthesis, you really must determine if the mandible has a height of greater than 10 millimeters. You must establish the implants in a position where there's at least 10 millimeters of restorative space above the soft tissue clinically. And for a fixed prosthesis, which is not relevant today, we need 10 millimeters of anterior posterior spread. Maybe I'll come back sometime and talk to you about the so-called fixed prosthesis or implant supported prosthesis. Regarding mandibular height, there's a diversity in dimensions. And while we rarely see people edentulous for 30 or 40 years today with severe resorption, today it is more common to see patients with either recent resorption or moderately rapid resorption. And these patients present with challenges of having almost too much bone and not enough room for the abutments in a prosthesis above the bone. And so we really must take great appreciation of the dimensions. Some general guidelines for you all is that if you see the mandible on a panoramic radiograph is perhaps more than 15 millimeters or 18 millimeters in height, you will find that the bone is already encroaching on the space one needs for the strong implant prosthesis. You may actually be in a community where a Panorex is not available, and so clinical guidelines are important, and I'll highlight how that can be managed. The mandibular height must support at least 2 10-millimeter implants that can support the mandibular retained overdenture. Here you see an 18-millimeter mandible with 2 12-millimeter implants in place. And of course, this is all that is needed to change this patient's life, to give them dignity, to give them function. The second rule of 10 is 10 millimeters of restorative space. And this is truly the most important. From the occlusal surface to the soft tissue, there must be 10 millimeters of height. Otherwise, retaining the space for the abutments and the housings and all the other function, you will have an insufficiently strong acrylic denture, and the denture will eventually fracture. So to prevent the risks of fracture, we want a denture that it is at least 10 millimeters from the incisal edge to the soft tissue. Radiographically, that's approximately 13 millimeters from the bone to the incisal edge. The rationale is that a prosthesis that resists occlusal load and mechanical failure and also provide for hygiene cannot be made with using less than 10 millimeters of restorative dimension. The way to look at this is schematically, you have an implant in bone, you have an abutment through the mucosa that is 3 millimeters tall. The housing that retains the denture, the so-called overdenture housing, is also approximately 3 millimeters in height. And minimally, you need 3 millimeters of thickness of acrylic resin. In an ideal world, the tooth sits above this complex of abutment and housing, and so at least 6 millimeters above it. With a tooth approximately 9 or 10 millimeters, you find yourself 15 millimeters from the bone. In contrast, if you are building or if you have not accommodated for this by reducing the level of bone in the mandible, or perhaps not accounting for the height of the denture through the vertical dimension of occlusion, then you find the teeth are sitting on top of the soft tissue. You have a large, bulky region of acrylic, which impairs one's speech, makes this very uncomfortable for the individual. And in these regions, perhaps the denture can become very weak and fracture eventually. Prosthesis dimension is very important. As you see, a denture can fracture in the midline. This is because the denture is actually too thin. More frequently, it doesn't fracture in the midline, it fractures through the abutment housing. Here you see the locator housing, and the acrylic resin is actually less than 1 millimeter thick. This is 3 millimeters too thin. And the solution was to remove enough bone to create a soft tissue level here, not here. So we want minimal restorative dimensions. We want room 3 millimeters through the soft tissue, 3 millimeters for the housing, and ideally the tooth sitting above the level of the housing. So from bone to occlusal surface, about 13 to 15 millimeters. And this creates an outstanding prosthesis. 10 millimeters of AP spread is a story for another day. So let me just move beyond here and tell you where to place the implants. Well, it's not where, but really why we place implants where we do. And the reasons we place implants are, number one, to stabilize the mandibular denture, to enhance the function of the mandibular denture, and not to reduce the strength of the mandibular denture. So in stabilizing the mandibular denture with 2 implants, it's very important that we think about where in the anterior posterior region of the mandible we place the implants. I will show you in a minute. This also relates to how we enhance the function of the mandibular denture. And if you do not remove bone to create height for the mandibular prosthesis or restorative space, you will not have enough strength for the mandibular denture. So consider denture function. On your left, you see 2 implants that are placed along an axis that is perpendicular to the midline of the patient. In this way, when the denture rotates, it will rotate freely from any of the anatomy on the lingual surface of the mandible. However, if we place the implants in such a manner that the axis of rotation made between the 2 implants is not perpendicular to the midline of the mandible, when the patient's mandible rotates on the lingual aspect while it across this axis, it will always impinge on the relative undercut areas in the mandible. So every time the patient chews and food lifts this denture by sticky food actions, it will rub and irritate the patient. So you can see that mechanically, considering denture function means we must be very careful about where we place the implants relative to the midline. In addition, one could consider placing implants in the canine position. In doing so, one makes it difficult to, to challenge implant rotation. If we have the implants in this posterior canine position, for example, now the denture can rotate and anteriorly and posteriorly. If I go back one here, the denture base has no function anteriorly, so as it rotates in an upward position with sticky food action, there is no impingement here. Here, with the axis being located posteriorly, now the denture impinges both posteriorly and anteriorly. This creates complications and discomfort for the patient. So the solution, my friends, is implants should always be placed in the lateral incisor position of the mandible in a manner that the axis of rotation is perpendicular to the mandibular midline. You do not need any special hardware. You do not need a cone beam CT. All you need is to understand the construction of your denture, which I'll show you. The treatment concept we're using is the 2 implant mandibular overdenture. The implants will be placed parallel to one another in the lateral incisor position of the mandible. In preparing for surgery, we always follow the fundamentals. Is our patient healthy, ASA class 1 or controlled class 2? Have we made a good denture to drive our diagnosis? Have we assessed bone quality, quantity, and morphology? I'll speak to this later on as we continue. Have we created a surgical guide or a template-guided surgery so that we assure that the implants are placed where we designed them based on our denture function? And then do we perform a stepwise osteotomy and a mucoperiosteal flap to achieve the surgical goal in a minimally invasive manner? Do we prepare the osteotomy with copious irrigation while cutting up the bone to reduce heat and reduce damage to bone? And do we place the implants such that they achieve primary stability? We always follow these fundamentals. So for us, we begin with a denture-directed surgery. I apologize that here you see the incorrect position, not in the lateral incisor position, but here you can see it corrected. And now you can see two things, a very simple guide using clear resin. It does not need to be clear resin. It could be the exacting denture. We can identify the amount of reduction to get to 10 millimeters. This is the existing height of this patient's mandible. And this distance from here to here is 13 millimeters to the bone crest. Looking in the other image, you can see that we've designated the position of the two implants such that the line between the two implants is perpendicular to the mandibular midline. This is made very simply by duplicating the existing denture using a putty index, one could use alginate, to cast this in acrylic resin. So one only needs maybe alginate or some putty and the existing denture and some inexpensive acrylic resin to make this guide. Again, in guiding principles for implant surgery, we've prepared our guide, we have cleaned this guide, we have developed profound anesthesia for our patient, and in the parasymphyseal mandible, there's no need to do a mandibular block. This is simple infiltration surgery. We're going to speak in a moment about preserving vital structures. There are very few to worry about in the lateral incisor position of the mandible. We can achieve hemostasis very easily. There's very little to damage here. Preventing infection by having a sterile field, and of course, attaining primary stability. The one concern you may have in the anterior parasymphyseal mandible is the inferior alveolar nerve and the mental foramina, and recognize that it is typically located between the first and second premolar, sometimes close to the first premolar, rarely anterior to the first premolar. However, the anterior loop can extend all the way to the lateral incisor. The good news is it does this in very rare cases. I don't believe that the dysesthesia or paresthesia creates a significant problem, and without access to a cone beam CT, you will never see this device. One of the advantages of placing implants in the proper location in the lateral incisor position is it keeps you from having concerns about damaging the mental foramen and this anterior loop of the inferior alveolar nerve. So again, a patient comes to our clinic, he has 2 new dentures we've made for him, and to complete the therapy, we have scanned, and again, now you can see just what I was talking about. Placement of implants in the lateral incisor position moves us far away from the vital structures of the inferior alveolar nerve and the mental foramina, which are located beneath the first and second premolars. This cone beam CT illustrates exactly what we're speaking of, designing the case. Here we have two 11 millimeter implants placed in about an 18 millimeter, 19 millimeter mandible. However, the implants are going to have to be placed more deeply to allow for a sufficiently thick denture. So looking in cross section, you can see that the implants are placed below the crest of bone. The crest is high up in the denture. And for us to have a strong denture, we've recognized that we must remove approximately 5 millimeters of bone here, 4.99 millimeters. Also, we need the width of the mandible to be at least 6 millimeters, and at the crest, it's very narrow. So the implant would not be in bone in this crestal region. One does not need a cone beam CT to understand this. This is visible at surgery and is anticipated in most non-resorbed mandibles. Looking again, seeing that the mandible, the implant is placed midway between the buccal and lingual cortex. It is many millimeters below the lingual surface of the denture. It is placed approximately 5 millimeters below the bony crest. So we need a surgical guide that demonstrates where this access is, how we will drill this hole, and how deeply we will create the osteotomy. And so my surgical guide displays this, and I'm able to then proceed, marking my osteotomies, showing here. And then, unlike most surgeons, I typically do something very different. I use my pilot drill to drill through here in the mucosa so that I have marked my bone prior to making a mucoperiosteal flap, because the mucoperiosteal flap can often displace the surgical guide. Here you can see I've raised my flap, and now you see that my osteotomy is not on the crest. And if I go back, you can see it's exactly where we designed it. Here is the crest, lingually positioned. And now exactly as we planned it, the other is hidden, full mucoperiosteal flap, only opened here so that we can remove this bone with a rongeur. One does not need special instrumentation. And now I can continue with my osteotomies using a surgical guide, and then in the reduced bony condition, making my osteotomies and assuring parallelism. I think the implants then are placed. And in this case, you can see we're now ready to place healing abutments or abutments and deliver this denture. So this is the way we use a surgical guide in making a denture. Now, let me go through another surgical case. This is a gentleman who I treated back at Illinois just a year ago before I moved to Virginia as the dean, and I had made him this beautiful digital denture. That's a topic for another day. He was happy, he was comfortable, but he, at 70 years old, is a personal athletic trainer, very physical, very robust, and looking for improved function. And so what I did for him was offer him a very helpful solution, which would just take us another hour of surgery to improve his condition, which is to implant overdenture. And so we used a cone beam CT. This is called a dual scan. We see the denture superimposed, and now again, under the lateral incisors, far away from the inferior alveolar nerves, I've designed the placement. In his case, we have to consider the bone type. Most mandibles are type 2 bone, but occasionally bone can be very thick. In our African-American population, we often see type 2 bone, but occasionally type 1 bone in the parasymphyseal mandible. This is important because this type of bone must be treated very gently so as not to damage the bone when drilling, as you'll see. Now you can see the bone density. There's basically no bone marrow. You see the outline of the denture. You can see again that I need some height in this prosthesis. And so we've placed the implants approximately 5 millimeters below the crest, not because we don't have width here, but because I need strength for this very powerful man. In this case, we have his previous triune denture, not in clear resin. And so to be able to see, instead of making a line here, we have his teeth where the mucosa is, and then this is the level to which I must reduce bone. And again, beneath the canine, beneath the lateral, and behind the lateral incisors, the osteotomies. So we're going to do the surgery just as I showed before. The first thing I'm going to do is make my transmucosal markings of implant positions, and the implant drills must be parallel to one another at this very first. First, the right position, followed by the left. And we drill approximately 13 millimeters from the prosthesis allowing us to have about 8 millimeters of depth to this transmucosal marking. Now, following that, a mucoperiosteal flap is elevated. And now I'm going to have to make an alveolectomy. And I will measure from the cone beam CT. I knew I needed to remove about 5 millimeters of bone. And so what I'm going to do is, after making the mucoperiosteal flap, I do my osseous reduction. I then place my prosthesis in the mouth and I evaluate whether I have achieved the reduction I want. Now you can see from this guide, I have room for teeth and approximately 5 millimeters for the housing and acrylic resin beyond it. We always focus on a prosthesis dimension. You can see in this drawing that we have less than 10 millimeters of space, and now the teeth are actually in front of this, and there's this large, uncomfortable, very thin area that often fractures. In the cases where we have 10 to 15 millimeters, we can often just get by, and we have to be careful when making our overdenture that this prosthesis has sufficient thickness. And finally, when I have more than 15 millimeters, I can set my teeth above the prosthesis and have adequate thickness and strength for everything here. And in fact, this is the condition that I created for this patient. So to increase the amount of bone, prosthesis or restorative space, we actually have to decrease bone. When we are working with dentate patients, as you'll see in a few minutes, we often have to, well, not often, we always must do an alveolectomy. So parallelism is very important, and we follow along not using a guide, but using our vision. A drill is placed in one site, we continue on with the other, we go to the next size, and we continue on with the other. We go to the next size and continue on with the other, flipping these drills back and forth to make sure we finally create our osteotomies at the proper height. Now, the dense bone beyond the cortex in this patient is obvious. So the first thing we're going to do is we're going to open the crest of bone to just about the same dimension of the dental implant. It's very important not to create pressure necrosis. We do this in the left side and we do this in the right side. And you'll notice that we plan the osteotomy to be in the middle of the bone so that as we expand the osteotomy, we don't make a hole or a fenestration through the buccal or the lingual aspect of the mandible. Now, in type 1 bone, you must use a bone tap for many of these dental implants. So in this system, this is called the prime taper system from Dentsply Sirona, we must use a bone tap, and we will tap the bone for the first 8 millimeters. And in tapping the bone, we create the threads that allow the implant to be placed without significant pressure. The implant is threaded and it has micro threads at the top. And you can see that now we can carefully place our implant till the implant abutment interface is directly at the bony crest or slightly a ½ millimeter below the bony crest. Now, in this case, I can place 2 healing abutments. You can see the alveolectomies performed. The implants were placed between the buccal and lingual crest nicely. The alveolectomy is perpendicular to the interpupillary line. My flap I've designed does not have any tears to it. And now I must carefully close this. Now, if I can go back, you see these abutments are nearly parallel, except here where there is an undercut region. And what we want to do in closing this flap is use sling sutures around the abutments to tightly hold the mucosa in that undercut area so that the tissue does not move up and down when the patient functions during healing. You'll notice we've just closed the release incision with some interrupted sutures. Very simple to perform. And when you're done, you see how nicely closed this case is. 8 weeks after healing, our patient returns with the 3 millimeter healing abutments in place, intact, and the mucosa is healed nicely. The implants have integrated, and you can see that the mucosa is very healthy. What's important is we have beautiful keratinized tissue all the way around the implants. At a later date, I might be able to talk in more sophisticated language about this problem, but I will come to this in our next case. At that visit, we place our locator abutments, and now you see the housings in place with these plastic rings beneath them to prevent resin from getting into the interface area. Locators are a brand of abutments that have housings with resilient liners that retain the overdenture. We must pick these up into our denture, and it is best done clinically, number one. Number two, we pick up with the patient dentures closed in centric relation, and we use different materials. You can use a quick setting methacrylate, a bisacryl, or a composite. These materials come in various types and various brands. Some are expensive, some are very inexpensive. And in looking at these materials, I strongly advocate not using the expensive bisacryl materials, but actually the cheapest of materials, which are polymethyl methacrylate materials, and finding a quick set material. This one material, for example, is not pink, but it is tooth colored, but it sets in 2 minutes. And these are the types of materials you want to use to place around your housings to be picked up in the denture. Now, in picking up the housings in the denture, one must create spaces. Now, the denture, the locator housings are approximately 6 millimeters in diameter. So the holes we must make must be approximately 8 millimeters in diameter so that none of the acrylic touches the housing none of the hard acrylic touches the housing when the denture is seated over the abutment and the abutment housing. The patient will then be closed into centric relation, and that relationship will seat this denture ideally versus the maxillary denture or dentition. If these hard surfaces were to contact the locator housings, then it would shift the position of the denture and invalidate or confuse your occlusion. So we always perform our pickup as a closed mouth pickup in centric relation. If you ask the patient to close and you find the teeth are not in ideal intercuspation, then you need to open the space for the housing even more. So we've now picked up the housings. You can see I created sufficient space. We've picked this up with rapid setting acrylic resin. I've removed any excess resin from the denture. You don't see any here. You see the line here and here. And now we must select retentive elements. And there are different types of retentive elements that can be placed within here. One can look very carefully. You see a little excess acrylic resin here, and I've removed it carefully here. Now, there are the black processing caps that come inside the locator housings. If I place the locator at the time of surgery, I use these black non-retentive elements for provisional loading. My go-to, or the typical way I use these, are to use the light retention elements. This is what satisfies most patients. Perhaps some patients need higher retention, and you can only figure this out by having your patients wear something. So I typically begin with the pink. There are also extended range that are lighter and stronger that you can purchase. But for the most part, these three that come in the kit provide you with the greatest opportunity for success. So again, we've delivered the denture, we've checked the centric occlusion. We have not altered the occlusion for this patient. We've not altered the external surfaces of this denture. It still looks very beautiful, and our patient can return happily. So with mandibular implant overdentures, we know that there are high implant success measures. The implants succeed very well. We know there are high patient-reported outcome measures, or PROM measures. Patients say they feel better about themselves. Physiologically, we reduce bone resorption in the posterior mandible when we load the anterior mandible with an overdenture. However, these patients still may require relines over time. Also, the housings or the resilient liners, these devices made of plastic, will need to be replaced on a regular basis, typically annually. Patients tend not to come annually. I will also tell you that the reason for having parallel implant placement is parallel implant placement reduces the wear on these resilient liners significantly. So it is important to think about parallel implant placement. I want to close today by talking about what is probably more common, and that is overdentures as treatment for the terminal dentition. This gentleman came to our clinic and he was in need of dental therapy, dental caries, old crown and bridge, and needed some help. You can see we're going to do this very simply without anything more than a Panorex to guide us. He has some root tips. He has an enormously large mandible. The inferior alveolar nerve exits the mental foramen here. Our lateral incisor positions are far away. But he's vertically closed. You can see there's no posterior dentition. So I'm going to have to define what my vertical dimension is to create restorative space. You'll also see the mandible seems to have modified itself by showing upward remodeling. So there's more mandible here than was needed, and I'm going to have to reduce that. I begin this treatment by making dentures, starting with simple alginate impressions. I identify my important landmarks, such as the hamular notches and the retromolar pad areas, to make certain that I have incorporated all of the anatomy required. And then I take some time to very carefully mount this in centricalation using stabilized record bases and occlusal rims. And now I have this all mounted carefully on a semi-adjustable articulator. This allows me to open the vertical dimension as required to create space and also to begin therapy. Now, I'm using his existing dentition to define the aesthetic landmarks. And in doing so, you can see I've transferred his midline and occlusal plane beyond the teeth and the intraoral landmarks to the land area on the cast. You'll also notice I've removed only half of the teeth, and I've set a central incisor, a lateral incisor, and a canine in what I consider to be an ideal position after thinking about bone removal. I continue this therapy by setting posterior teeth halfway up, 3/4 of the way up the retromolar pad. And you'll notice I'm preserving my landmarks here. I've identified where I think the bone needs to be removed. And you can see I'm now setting teeth. And I actually do this to preserve my landmarks of who the patient is. And then I can return to set the remaining teeth. It's an odd way to do this, but a very effective way of knowing where I am at all times relative to what my landmarks need to be for surgery. When I have established my midline and my occlusal plane and have a reference point for bone removal, I can then go ahead and process these dentures. So finishing my wax up and then transferring this by simple processing, heat processing of acrylic resin and denture teeth, I now have my dentures. Now, we're going to make this very simple. I'm going to use this denture as my surgical guide. In the maxilla, we're going to head and remove his teeth. I've made a copy of his of the altered cast and made a clear thermoplastic guide to guide my surgery. And I have proven that I have removed enough bone, and I can seat this guide on the palate so that my denture fits beautifully without modification of the denture or relining of the denture. We turn our attention to the mandible. We remove the teeth and with it some of the keratinized mucosa. We use a surgical guide again to determine if I've performed a sufficient alveolectomy. You can see that I still have sockets here from the canines and a straight line mucoperiosteal flap. You'll notice I've done this just below the necks of the teeth. That way, when I close this case, I can close this beautifully without the interproximal mucosa interfering with the seating of the denture. So again, we plan these cases for depth of implant placement and perform an alveolectomy. This is a different case, but demonstrating that we try to organize our thinking around the restorative dimension required in all cases. Returning to this case, you can see that I removed bone in all cases. The central incisor and this one lateral incisor socket is almost obliterated. The same tricks you saw before. I've drilled for the one lateral incisor, keep the drill in place so I can have parallel form for the second, expand the osteotomy, completing my osteotomy and placing my implants, and I will place them at the crest or a millimeter below, and then place, in this case, ball abutments, and now carefully close the case, again with sling sutures. You can see the tight tissue here and here, closing the case, and now identifying where the ball abutments are using a little material here to identify how to open this denture. And then we can either use healing abutments or final abutments. Here I've used something called a clicks, not a locator, and I can provide some stability during healing. And I do that by relining this with just a little soft reline material. So I can then come back later and pick up my attachments. So for immediate provisionalization of an overdenture, the implants must be placed with primary stability in the absence of infection. The intaglio surface of the denture is relieved around this. That's what you saw me doing with the purple material. I can go back here now to relieve where the overdentures were. And then reline the denture using a resilient liner. There are lots of materials you can use. There's a VPS material that is very quick called GC Soft Line Reliner, but you can use a very inexpensive soft lining material like Linol, which I don't care for, or GC Co-Comfort or Co-Soft, which will work equally well. And the retention of the liner will be noted by the patient because the denture will not move left or right, although it will still move up and down. So this provides the patient with some stability improved stability compared to a conventional denture. And then 6 to 8 weeks after surgery, we place our final attachments and activate the denture. And then you can perform a remount procedure if you wish to finalize the denture occlusion. Here is our patient. Even though we've performed a remarkable alveolectomy, you can see the denture in place and quite remarkably the space to provide 10 millimeters of distance here to allow for good function, and he will go home and heal. Here is our patient 2 weeks after surgery. You notice the soft tissue is healing very nicely. He has a way to go yet, but here are our implants. We've left his tori, and you can see aesthetically, he's much improved and very happy. And then at 8 weeks, you can see things have healed very nicely, some significant resorption in his case. Instead of simply picking up the attachments, because of the amount of resorption here, we actually are performing a reline procedure by taking an impression of the mandible and reprocessing the denture. Our patient returned at 1 year, and you can see the remarkable resorption. These abutments were transmucosal at surgery. After healing in a year of function, you can see approximately 2 millimeters. The implants are still at the crest of bone, and our patient has healed beautifully with no denture irritations located anywhere. And again, from a lingual perspective, very good health, very good function. Looking carefully, some plaque on his denture, suggesting he can certainly improve his hygiene. And if I go back again, you'll note high keratinized tissue abundance, a lot of keratinized tissue here, which is very important for denture function. And our patient is very, very well served. And remember, we've moved this patient from teeth to no teeth. And again, implants under the lateral incisor position in the middle of the alveolar ridge with significant thickness of acrylic resin everywhere here to assure long-term function for what is a very beautiful denture. So I've shown you today a couple different ways of thinking about mandibular implant overdentures. What I wanted to summarize for you is that removable prostheses are an important part of prosthodontic success in some practices in society. And that when we think about this, yes, digital technology improved it, but it doesn't impact patient outcomes and community-based healthcare. We do not need the fancy technologies you hear and read about to deliver a wonderful mandibular overdenture prosthesis. But dental implant augmentation of a removable prosthesis has measurable effects on patient-reported outcomes that support the strong recommendation for its use. Any patient who can benefit from, well, all patients can benefit from implant-supported removable prosthesis. And we should offer it to all of our patients, and we must develop opportunities and ways of providing this care for our patients. There are some very simple things you have to learn. Follow the rules of 10. Always begin with beautiful dentures. Always think about restorative space. Always remember the fundamentals of implant therapy. And recognize that placement of 2 implants in the lateral incisor position gives you some breadth of safety that makes this characterized care something that is addressable by many and not few. Uvo, I hope that perhaps I've shared some enthusiasm today about my favorite therapy in dentistry. I'm going to stop sharing my screen and come forward.
Okay.
And I think I'm right on time today.
Yes. Thank you so much. I wanted to go back. I saw a patient a couple of days ago, and I noticed that the patient complained that she has 2 implant overdentures, and she was complaining that one of it doesn't snap in as tight, or and I looked at it. It's as though there was some excess of material covering the thing itself in terms of, but a quick question here. How do you determine, can we go back to, I know you put determining the restorative space, because I realize that is mostly the big problem, because most people just edentulate without calculating, the size of the prosthesis. Then they just put anything there and they come back.
The simple thing to do is you begin by making new dentures, correctly? So if the thickness from the incisal edge to the intaglio surface of the mandible is not 10 millimeters, you have to create space. So say you measure somehow with a caliper or some other way the distance from the incisor to the intaglio surface of the denture. If that is not 10 millimeters, say it's 6 millimeters. Now you know you must remove at least 4 millimeters of bone, maybe more. And so that's why clinically one can perform these wonderful therapies if you think about principles and not devices. For us, the principle is we need restorative dimension. There's 2 ways to get it. You can open the vertical dimension. Sometimes that's a problem, but you can't open it too much. Or you can reduce the bone, right? It's the same thing. Do you raise the bridge, or do you lower the water?
Yeah.
So that's the best way to do it, is to do it clinically, to just make your denture first and figure out where you are in terms of that space.
Yes.
Must be 10 millimeters.
Yes. Yeah. Because most people would come back. You think you start having things that break. If it's too thin, then something is going to give at the end of the day.
It always does. It always breaks.
Anyway, we do have, folks. So what I did when I went to Nigeria was to create dental implant study clubs in different cities, such that the people can come to, so that they can stay together and learn together. And most of them from the eastern part of Nigeria are only on this call today. I just saw them about 3 weeks ago. Anyway, we're looking forward to you coming back. You said you wanted to talk about next time on my first single implant placement, or most people want to try. They want to.
Well, we can do that, right? We could go through a very simple, my first single implant. So maybe in a couple of weeks we'll come back and do my first single implant.
Okay.
We'll do it all analog, no fancy digital. We'll make it for the community of people that have an office with a drill and a motor and a patient.
I think those are the people we have on this call as of right now, because I went around the city of Abuja as the nation's capital. I couldn't find a CBCT machine. In one of the other cities, I found it, but most people, in terms of, they didn't even have a lab that could, or anybody who could integrate the CBCT with the patient's record to be able to plan a surgery for them.
Yep.
So that is on there. But anyway, that'll be interesting.
James has just made a wonderful comment about today's lecture too. James says the other option is to do a metal mesh reinforced acrylic frame to increase structural durability. James, you bring up a very good point, because in the United States, the cost of having that metal mesh put into the denture is less than the cost of a denture repair. And so if you think about that as a preventive measure, maybe if you're making a mandibular overdenture, you want to think about adding a metal mesh into your denture. There are bench studies that suggest the metal mesh is not as effective as thicker acrylic resin. So I would argue that if you don't have dimension, then the metal mesh is okay. But one should always consider creating that dimension. I want to take another minute and tell you, if you go around the world or around my country, the United States, people teach you this is a very easy surgery and you can do it flapless. Well, the truth is, I find it's a very challenging thing to teach, and it cannot be done easily flapless, and it should not be done flapless most often. And if you do a flapless surgery, then you need a cone beam CT. And so one should always consider the opportunity to remove a little bone is a great way to increase the longevity of these prostheses. And mini implants, 4 mini implants cost as much as 2 real good ones. And so I'm not a big fan of mini implants. You see those. Someone else can talk to you about mini implants.
Anyway.
Great point, James.
All right. Anyway, thank you so much. If there are any other questions, you can type it. But I think it's been a wonderful, and it's recorded, so we can go back. I mean, you have to really slow down the video and pause it and take some notes, because almost every slide is full of great information. Thank you, Dr. Cooper, and I would say looking forward to BA. Yeah. All right. Thank you.
Have a good evening.
Okay then.
Bye-bye.
All right, Dr. Colley, I see you. Thank you, Dr. E. Warhard, Dr. James, Dr. Louis Essien. Thank you so much, Patrick Uwem, Dr. Osagbemiro. It's good to see you, Dr. Rafiat, Dr. Wanyama, Dr. Bere, Dr. Okoye Uzu. I see you, Dr. Bowale. Thanks for joining us today. We're running up this second phase here. We're going to have a very interesting one, the single implant. I think the single implant is where most people want to place their first implant. So we are looking forward to having that lecture, next week. And Dr. Carlos Coley is going to talk about the fixed prosthesis. That is the ultimate. By the time you finish doing all that, you want to go and do a fixed prosthesis, which is where it's becoming the bread and butter for many practices. Anyway, looking forward to see you guys next week. You guys take care and have a wonderful rest of your Sunday.